Okay. So what is infective endocarditis? As the name suggests, is the infection of the endocardium by microorganisms. Okay. So what is the characteristic of this infective endocarditis infection? So there is a bulky friable vegetations. Now what are vegetations? Okay, so these are micro-colonies of the organisms. Okay, the organisms colonize in your heart endocardium along with the platelet, fibrin and other inflammatory cells. Then they form some ball-like structures. Okay, so these are known as vegetations. Okay, and the characteristics of infective endocarditis vegetation is they are bulky and friable. What is bulky? It's a bigger in size. And friable are, what is friable? Easily breakable. Okay, so they're easy to break. So most common site of these vegetations are your heart valves. Okay, then you have the lower side pressure side of the VSD or the mural endocardium. Now why it is heart valves? Why not other spaces generally? Physiology. Any idea why the heart valve is involved? Any idea? It is due to the blood flow. Okay, so the blood flows or the turbulent flow of the blood is through the valves. Okay, so the lower side, lower pressure, okay, of the valve is always involved. Okay, because that is the site where the vegetations will drop and they will colonize there. Okay, so classification we have acute type and subacute type. Okay, so what is the difference between acute and subacute? So acute endocarditis, mainly it is rapidly progress. Okay, within few weeks or days. Okay, mainly it involves the normal cardiac valve. Then it is implicated with a high virulent organisms. Okay, etiology is a high virulent organism like Staphylococcus aureus. Okay, and it causes substantial morbidity, mortality with appropriate antibiotic therapy also. Okay, so it is having a rough course of disease. Okay, and it is less common, 10 to 20% only. Okay, so more commonly we have the subacute type. So subacute type is slow. Okay, slow progressing. Okay, mainly it involves the previously damaged heart. Okay, like it is already scarred or deformed, the valves are deformed or scarred. Okay, then the implicated organisms are of lower virulence. Okay, like Viridans, streptococci, cons, all this. Okay, and it follows a gradual progressive course of the disease and most patient can recover. Okay, it is the most common type, 50 to 60%. So what are the risk factors for infective endocarditis? Most common is if there is any scarring or damage to the heart valves. Okay, so the underlying cardiac defects like mitral regurgitation, aortic stenosis, aortic regurgitation, VSD. Okay, when the heart valves are deformed, and use of intravenous catheters like central lines. Okay, they go directly into your heart chambers. Then prosthetic valve replacement therapy. So what is another common type? So you have valve replacement therapies. So after you replace the valve, you put some prosthetic valves. So those prosthetic valves are the site or the nidus of colonization or the formation of vegetations. Okay, so how this infective endocarditis, what is the pathogenesis? Okay, first we will have the endothelial injury. Okay, so endothelial injury mainly by the predisposing factors like your risk factors. If any IV catheters are there. Okay, so it will go and damage the endothelium, and first what it will form? It will form non-bacterial thrombotic endocarditis. So you have to note it. Okay, NBTE. So first stage is your blood flows causes damage to your heart valves, and it is known as NBT, non-bacterial. There is no bacteria now. Okay, it is already the damaged valves, and in this damaged valve, if the blood flow occurs, then platelet, fibrin, all the components of the blood will accumulate and they will form NBTE, that is non-bacterial thrombotic embolism. Now this non-thrombotic embolism this is the site of colonization of the bacteria. Okay, so there the bacteria will attach. Now how does bacteria come? You are having in the heart, it is a sterile condition, it is a sterile area. Pure blood is going. There is no chance of bacteria in this heart, this one blood. Na? So from where the bacteria come then? So this is known as transient bacteremia. Okay. So how this transient bacteremia occurs? It occurs due to injury to any of the mucosal surfaces, commonly the oral mucosa. Okay. Then you have the GIT, you have the gastrourinary tract. Okay. So most commonly oral mucosa, like dental extraction. You are having some dental problems. You have extracted your tooth. So you know the oral cavity is a habitat for many commensals. Okay, you are having commensal bacteria in your oral cavity. So if there is any disturbance in the oral cavity commensal or the habitat, it will lead up in bacteremia. Okay, so they will travel into the heart. That is how from the GI tract also, if you are doing any invasive procedures like colonoscopy, endoscopy, all this thing, any surgeries related in your oral cavity. Okay, tooth brushing also one common factor. Okay, you are brushing the tooth roughly. Okay, sometimes you can hurt. Okay, hurt your mucosa. So from that mucosa, the bacteria will travel and go into the heart vessels. Okay, tonsillectomy, endoscopy, then colonoscopy. So these are the causes of transient bacteremia. And why it is known as transient bacteremia? Because it is for a short period of time. Na? Okay, so you are doing a tooth extraction, after that only it will occur. It won't occur always. Okay, it will be during that pathological period. Okay, now what happens? Now these bacteria travel along with the blood flow to the heart chambers. And already in the heart, what is formed? Non-bacterial thrombotic emboli. Now this emboli will colonize these bacteria. Okay, so bacteria will go and attach to those NBTE and they will start multiplication there. Okay, so platelet plus fibrin plus inflammatory cells along with the organisms, they form the bacterial vegetations. Okay, or the infective endocarditis vegetations. Now I have told it is already fragile or friable. So most common cause of metastasis. Okay, it is friable, so it will, as the blood flows, it will break down with the blood, turbulence of the blood, and it will go and travel to the other parts of your body. Okay, like your brain, kidneys, liver, anywhere it can go. Okay, so metastasis to distant sites because it is friable. Okay, so it easily breaks. So you have the endothelial injury, you have the NBTE, that is the non-bacterial thrombotic endocarditis. Then you are followed by transient bacteremia. Bacteria will go and enter or attach to the NBTE, and there the multiplication or the proliferation of the bacteria will occur, and it will lead to infective, fragile, bulky vegetations. Okay, so you can appreciate the vegetations. You can see what are these? Chorditendinae. Okay, what is chorditendinae? There are some muscles that are attaching the valves with the wall of the heart. Okay, so you can see this is the valve. Okay, this part is your valve, and below the surface of the valve, where there is slow flow of the blood, okay, there the vegetations will come. Okay, it won't be seen in the upper side. So clinical manifestations, if it is acute, then it is within days or weeks, and if it is chronic or subacute, it is months. Okay, so mainly the symptoms are your fevers, chills, sweats, okay, myalgia, arthritis, are common symptoms. But what is your definitive symptom? What is the cardiac symptom you are having? It is the murmur. Okay, So what is murmur? Yes. So appearance of a new or worsened regurgitant murmur. So it is always diagnostic of infective endocarditis. Okay. Now you can have some peripheral manifestations. What are those peripheral manifestations? Because your vegetations go and travel to the other organs, the peripheries. Okay, so you will have osseous nodes, subungual hemorrhages, Janus lesion. Okay, all this thing. A laboratory manifestation, you will have anemia, leukocytosis. Okay, elevated ESR CRP. Now, elevated ESR CRP is a diagnostic of what? What are these? CRP, ESR. These are markers of, yes, sepsis. Okay, markers of sepsis or infection or inflammation. So always in a infection it will be raised. Okay, and some cases of rheumatic fever you will have the rheumatoid factor also in the blood. So okay, you can see this is Janus, this is a Janus lesion. So okay, so these are erythematous non-painful lesions on the palms and the soles. Okay, you can see these are erythematous lesions. Okay, so this is the second manifestation, that is splinter hemorrhages. Splinter hemorrhages are seen in the nail bed. Okay, so these are, it's not painful generally. Okay, and non-blanching brownish color lesions under the nail bed. Okay, you can see this, and this is osseous node again in the fingers and the toes. Okay, but these are specific and painful. Okay, they are very painful. You are seeing this. So this is the osseous node. This is subconjunctival hemorrhage. This is the conjunctiva. Okay, subconjunctival hemorrhage, and it is the retinal embolus. You can see this black dot. So it is an emboli in the retinal artery. Okay, and another characteristic is your Roth spot. Okay, it is again in the retina. Okay, so you can see this spot. So from top to bottom, where all infections or the manifestations can occur. If it is in the brain, then CNS manifestations. Okay, right? The emboli will go and lodge in the cerebral vessels. Okay, so it will lead to cerebral emboli. Okay, then it will lead up in stroke. Okay, or CVA. So if your eyes are involved, then subconjunctival hemorrhage. Again, you have Roth spot in the eye. Then in the mouth or the oral mucosa, you have the hemorrhages, petechial hemorrhages. Okay. In the heart, though, already told what is the manifestation of the heart. It is the murmur. Okay. Then we can have other cardiac manifestations also. Okay, like cardiac failure. If it is untreated, you will lead up in cardiac failure. Okay. Then kidney, it can involve. Okay, hematuria. Then spleen, splenomegaly. So in the hands, you will have osseous node and Janus lesion. Okay, and also splinter hemorrhages. Okay, and another important feature is your clubbing. What is clubbing? Yes, parabolic appearance of your nail or the nail beds. Okay. Now, what are the etiological agents? Most commonly, it is the gram-positive organisms. Okay, what are those? Staphylococcus aureus. Okay. Second, we have the coagulase negative staphylococcus, that is the cons. Okay, so cons is a normal commensal of your body. Okay, but it again acts as a major etiological agent for infective endocarditis. Okay, the streptococci, enterococci, pneumococci. Now some fastidious organisms like Hassek group. Okay, then you have the gram negatives, that is the enterobacterians, pseudomonas, and sometimes candida species in the nosocomial setup. Okay, if it is hospital like. Then diphtheroids. Okay, some specific type we'll have to know because there is a wide range of etiological agent. Now for which type of infective endocarditis, what all organisms are responsible, you have to know that. Okay. So if it is a native valve endocarditis, what is native valve? What is native valve? So own valve. Okay. so own deformed or the scarred valve. Okay. So if your own valve or your native valve is involved, mainly the Staph aureus is responsible. Okay. If it is community acquired, then it can be Viridans, but if it is health acquired, most commonly it is the Staph aureus. And the Staph aureus, generally it is MRSA. What is MRSA? Yes, so it is always resistant type. Okay, if it is hospital acquired. Okay, community acquired, then it is sensitive type. Okay, MSSA. Okay, so overall native valve infection is caused by Staphylococcus aureus. Okay, then you have prosthetic valves. So after surgery, your prostheses are put. So if that valve is infected, it depends on the type of invasion. Okay, if it is early, then what all organisms are responsible? Mainly the nosocomial. Okay, early matlab you are putting the infected valve itself, one possibility. Okay, you have not maintained the aseptic precautions, and during the operation only you have put the infected valve. Okay, so it can be from the hands of the healthcare workers or some contamination from your environmental surroundings. Okay, or it can be post-operative complication with bacteremic post like sepsis. So post-operative sepsis. Okay, so within 12 months, these are the most common organisms. Okay, nosocomial infection like Cons, Staph aureus. Okay, if it is late, then it is mostly community acquired. So we have the Viridans group. Okay, Viridans streptococci. And so overall, it is the Cons. Okay, so for prosthetic valve, it is always the Cons. Coagulase negative Staphylococcus aureus. Okay, and if it is IV drug users, okay, so IV drug users are more common to develop infective endocarditis. Why? Because they directly inject into your blood vessels. Okay, so they don't maintain any septic precautions and they do this procedure. So if it is right sided, so which valve will be infected? Most commonly tricuspid. So your right side is having the tricuspid valve, na? So most common is your Staph aureus, and if it is left sided mitral valve, then most common is your Enterococcus species. Okay, then overall you have the Staphylococcus aureus. Okay, for IV drug users. Okay, and if it is subacute type, subacute infective endocarditis, it is the Viridans streptococci again. Okay, some culture negative endocarditis is another variety you are having. Okay, culture negative endocarditis. Now all these etiologies you can grow on the culture, like Staph, Cons, all you can grow in your culture. But what is culture negative? One possibility may be you are already treated with antibiotics. Okay, so your body is responding, so you are not growing in the culture. Now another possibility is your fastidious organisms. Okay, etiologies can be fastidious organisms. Now what are those fastidious organisms? First group, your Hessek group. What is Hessek group? So we'll learn what is Hessek group. Okay, so these are the names of the organism. Okay, HACEK. There are 5 different organisms in this group. Then you have nutritionally variant streptococci. Then you have Coxiella, Bartonella, Brucella, okay, Tropharma. Okay, all these are fastidious organisms and they are very difficult to culture. So that's why you are having a culture negative endocarditis. Okay. Now how you diagnose endocarditis? So you have a criteria known as Duke's criteria. Okay. Now Duke's criteria was originally given in 1994. Okay. So this was only the criteria, but why it is modified then? Okay. So it is done for specification, for increasing the sensitivity and specificity of the diagnosis. Okay. So typical, we have the major and the minor criteria. Okay. So we have major and minor criteria for diagnosis of infective endocarditis. Okay. So what comes in the major criteria? you have two major criteria. Okay, first is your positive blood culture. Okay, so as it is a bloodstream infection, your sample will be always blood culture. Okay, you take the blood, you know the process of collection of blood now. Okay, so for the adult, how much will collect? Yes, 8 to 10 ml, and for the pediatric age group, 3 to 5 ml. Okay, so positive blood culture, if it gives typical infective endocarditis organisms. Now, what is typical infective endocarditis organisms? Those that can be grown in culture. Your staph, cons, enterococci, streptococci. Okay, so these are your typical organisms. Okay, so typical organisms in two separate blood cultures. Okay, now what is two separate blood cultures? Two separate blood culture matlab at two different timings, mainly 12 hours apart we collect. Okay, we take two sets of blood. Okay, two sets matlab first time we will take two blood culture bottles, again after 12 hours we will take two blood culture bottles. Okay, so this is known as blood culture sets. Okay, always you collect blood culture in sets. Okay, two at a time. Okay, and second criteria can be a persistently positive blood culture with other organisms that are not typical. Okay, like what are those? Coxiella, Bartonella. Okay, those are atypical organisms. So in those cases, again blood culture set is drawn 12 hours apart, and we take 3 minimum, or we can take 4 blood culture sets. Okay, and between these sets there should be difference of 1 hour. Okay, so the first set and the last set, between this the difference should be of 1 hour. Now from where this blood is collected? Mainly from the peripheral vessels. Okay, so again the site should be different. If you are collecting from the brachial ones, then you can go for the other site next time. Okay, don't go for the brachial or the same site again. Okay, so go for the different sites. Okay, now what is the second major criteria? You have evidence of endocardial involvement. So what are those evidences? You can do by echocardiography. Okay, echocardiogram. So you have a positive echo finding. What all echo findings you can get? Oscillating masses or the valves, abscesses or the dehiscence of the valves. That is, the valves are torn off. Okay, dehiscence. And second is new valvular regurgitations. Okay, so your regurgitation was your underlying risk factor for infective endocarditis. Okay, so if there is new valvular regurgitation in your echocardiography, then again it comes in your major criteria. Now you have the minor criteria. Now minor criteria are your risk factors like IV drug users. Okay, you will assess the patient. If the patient is IV drug user or patient is having any heart conditions, previous heart condition, already damaged valves. Okay, then you are having fever. Then vascular phenomena. What are the vascular phenomena I told you already? Hemorrhages, petechies. Okay. Then immunological phenomena like your osseous node, then Roth spots, all these things, and microbiological evidence of positive blood culture but not meeting the major criteria. Okay. So what can be those? Can be some serological tests. Okay, so how you define this endocarditis now? You have this criteria. Okay, so it is always two major criteria. Okay, if both the major criteria are present, it is definite of endocarditis. But if only one major criteria, then you have to have 3 minor criteria. And if no major criteria is there, so you have to have all the 5 minor criteria. Okay, so this is your modified Duke's criteria. Now in original Duke's criteria, you didn't have this specific or the atypical organisms in your criteria. You had only the typical organisms. Okay, so that was your Duke's criteria. But what happened with that Duke? So many other cases also were misdiagnosed. Okay, though the specificity was less. So that's why modification was done in 2000. And this atypical organisms were also included. Okay, now again in 23 we have some another criteria that is known as Duke. We have Duke IVSCID. Okay, so you have the International Society of Cardiovascular Infectious Disease and the European Society. Okay, European Society of Cardiovascular Diseases. So what they have included in this, another criteria known as FDG PET scan. Okay, FDG PET or CT scan. Okay, so this again improved the specificity of the diagnosis. So blood culture is very important for diagnosis. Okay, so always collect 2 sets of blood culture at an interval of 12 hours. Okay, and generally it should be prior to administration of the antibiotics. Okay, or any starting of the fever spike most commonly. Okay, then alternately you can collect 3 blood culture sets collected over 1 hour. Okay, so that's your diagnostic. Now what are the culture or the serological tests you have for diagnosis? Now some atypical organisms, Coxiella and all, okay, you cannot culture them. So what you will do, you will do the serological tests. Okay, so antibody detection mainly. Okay, Brucella, Bartonella, Legionella, then Coxiella. Okay, then you can have isolations of the pathogen in the vegetations by culture. Okay, you take the vegetations out and you culture them, then you can do the isolation. Now some microscopic examination with special stains, histopathology, okay, with a pass stain. Okay, then direct fluorescence, and lastly you have the PCR method. Okay, that will detect the DNA or the RNA. Now again, echocardiography is having a significant role in diagnosis. So why echo is important? We will know the confirmative position. Where is the position? Which area of the heart is involved? Okay, so the position of the vegetation, the size of the vegetations, or the complications that are following the vegetations, and assessment of the cardiac function. Okay, so again it is very important for the follow-up procedure also. Okay, so how you treat these infective endocarditis cases? Generally they are gram-positive organisms. So we will treat with the antibiotics that are covering the gram-positives. Okay, or the broad spectrum antibiotics. So if it is a native valve, which was the common organism? Staph aureus. So which antibiotic Staph aureus is responding to? Mainly penicillin. Okay, so penicillin was a drug of choice first, but now it has been changed to cloxacillin. Okay, so it is again a penicillin group of drug only. And if it is an MRSA, then it is already resistant to penicillin. So we will go for vancomycin. Okay, if it's prosthetic valve, what was the common organism? Cons. For cons, with this you have to start with rifampicin and gentamicin. Okay. Then for some other variants like Viridans and Escalolyticus, we will go for penicillin or ceftriaxone. Prosthetic valve again. Along with this, you will have the gentamicin. Okay. For Hessek endocarditis, treatment of choice is ceftriaxone. Okay, it's a 3rd generation cephalosporin. Okay, mainly for a month. And treatment can be extended if it is a case of prosthetic valve. Okay. Now, what is therapeutic drug monitoring? Now, it is a long-term course. Okay, for 1 week or 1 month or 1.5 months. So you have to monitor the dose so that optimum antibiotic is going in your blood, and also you are not suffering from overdoses. Okay, so vancomycin you have to dose say at 15 to 20 mg per kg, and gentamicin mostly 1 mkg per this one 8 hourly. Okay, so you don't need to remember this, but just know you have to do the therapeutic drug monitoring or the dosing. Okay. Now we'll see some special endocarditis case. So Staphylococcus, most common case, mostly the native valve is involved. Okay. So the vegetations are larger and more prone to emboli. Okay. They are more, as they are larger, they are friable and they are more prone to develop embolies. Okay. So cerebro, it can lead to some complications like cerebrovascular emboli, then kidneys, all the peripheral manifestations. So mostly they are seen with the staphylococcal endocarditis. Okay. So emboli is most higher chance in the mitral valve. Okay. Then cons also in the prosthetic valve. So these all are the gram-positive cocci. Okay. So how you diagnose Staph aureus and cons? First you do a gram stain. So what you'll see in the gram stain? What it is? Gram positive, negative. Gram positive cocci in clusters. Okay. And then in the blood agar, what you can see? What is this? You can see this part. Can you appreciate the hemolysis? So you'll see the beta hemolysis. Okay. So Staph will give beta hemolysis. And you can see this gram-positive cocci in clusters. Okay. Okay. And now how you are going to identify the species? We will do the biochemical test like catalase, coagulase. Okay. All this thing. Now Viridans streptococci. So it is a commensal of mainly the mouth or the oral cavity and the upper respiratory tract. Okay. And it is the most common cause of subacute bacterial endocarditis. Okay. How you diagnose? Mainly they are GPC in long chains. Okay. And they are having a alpha hemolytic colonies in the blood agar. Okay. So you can see these are the chains. So this is actually, the color is not appreciated. It is a gram positive actually. Okay. And you can see this is the alpha hemolytic colonies. It will be greenish in color. The color is not proper here. Okay. Now nutritionally variant streptococci, you have the abiotrophia. These are the, as the name suggests, it is nutritionally variant. Okay. So they are having deficiency in some vitamins. Okay. Mainly the vitamin B. Okay. So this vitamin B is required for them to culture. Okay. So they are normal inhabitants of the oral cavity. Okay. So how you diagnose? As they are very difficult to grow, so mostly we will refer to the molecular methods. Okay. Multitoph, Bacti-alert, all this thing. Okay. And one special characteristic they form is known as satellitism. What is satellitism? That is, if you grow them in presence of a nutritionally rich organism, those colonies near to that organism will be larger. Okay. So it is like this. So suppose you have grown this in a culture and you have a streak of Staph aureus. Now Staph aureus is nutritionally rich organism. Okay. They don't require any additional nutrients. Now when you grow this, when you culture this this variant, nutritional variant group, those near to this colony will be bigger in size, and when it will move further, it will be smaller in size. Okay. So this is known as satellitism. Okay. So this is your satellitism. So this property is also shown by some other organisms like Haemophilus. Okay. Haemophilus influenzae also shows satellitism. So how you treat them? Penicillin plus gentamicin. Okay. Now Galolyticus is a group D streptococcus. Okay. Again it is not present in, generally not present in your human body, but it can occasionally cause bacteremia and subacute endocarditis. Okay. Penicillin is the drug of choice. Now you have the Hessek group. Now Hessek group is, it's a highly fastidious, slow growing, capnophilic gram negative bacteria. What is capnophilic? CO2 lover. Okay. They love CO2. So they grow in the anaerobic conditions generally. Okay. Occasionally associated with local infections of both systemic and this one, mouth infections. So what are the HSEC group of organisms? For H it is the, you have to know this name, okay? H is for Haemophilus parainfluenzae, it is not influenzae, okay? It is parainfluenzae. Then A for Aggregatobacter, okay? Aggregatobacter species contains of Aggregatobacter actinomycetic emittens. नाम याद रख पाओगे? You have to remember this name, okay? And A Aphrophilus and Para-Aphrophilus. Okay, C is for Cardiobacterium hominis. Okay, then E is for Echinella corrodens and K is for Kingella kingi. Okay, so you have to know these 5 names. Okay, escape pathogens. Okay, so you have escape and was on your short form and HSEC is on short form. Okay, you have to know these 5 names. Mostly these organisms are commensals of mouth or the oral cavity. Okay. So they are opportunistic pathogen, they can cause endocarditis, conjunctivitis and other types of infection also. Okay. Then actinomycetic emittens, this is the most common member. Okay. And what is the etiology of all this? How does this HSEC group goes and cause endocarditis? If you have any injury in the oral cavity, that will cause transient bacteremia. Okay. Then again Aphrophilus, Para-Aphrophilus, commensals of mouth. Cardiobacterium mainly affects the aortic valve, okay? And Echinella corrodens. Corrodens meaning it is having some corroding or pitting type of growth in the culture, okay? So that's why the name corrodens. Okay, and Kingella kingi also it can cause some bone joint infection along with endocarditis. Okay, so how you diagnose in the lab this HSEC groups? Okay, we can do blood culture, but blood culture we have to incubate for a long period of time, maybe a month or so. Okay, then you have the molecular methods. Okay, like MALDI-TOF. Okay, or the conventional automated methods, or not molecular, it is automated methods like MALDI. What is MALDI-TOF? You know what is the full form of MALDI-TOF? Automated method में हुआ था ना? What is MALDI? Yes. And T or TOF is? Time of flight. Okay. So you have seen and told. So what is BacT-Alert? It is again a automated system for blood culture. Okay. हुआ था ना blood culture में? So molecular you have the PCR and the multiplex PCR types. Okay. So treatment, ceftriaxone is your drug of choice, and if they are resistant you can go for quinolones. What are quinolones? Which are the quinolones? What are the fluoroquinolones? You know, ciprofloxacin, moxifloxacin, levofloxacin. You have heard those names? Not heard. So these are your quinolones, and treatment again for a month or so, okay, 4 weeks. So we come to the end of this chapter. So what are the most common cause of native valve endocarditis? If it is native valve, then Staphylococcus aureus. Then if it is prosthetic valve, then yes, cons, that is coagulase negative Staphylococcus aureus. Then if it is IV drug user, then again you have the Staph aureus. Okay, and if it is subacute, Viridans streptococci. Okay. And what comes in your Duke's criteria? Modified Duke's. First is typical, first not atypical. First is typical infective endocarditis organisms. Okay. In how many blood cultures? Yes, 2 sets of blood culture you have typical organisms, or in 3 or 4 sets you have the atypical organisms. Okay. And next major criteria is, first is your culture criteria, then second is echocardiography. Okay, echocardiogram. Okay, and what is your minor criteria? Risk factors. Okay, first is predisposing risk factors, then fever, then yes, vascular phenomena like hemorrhages, petechiae, okay, the Genvais lesion, okay. Then you have the immunological manifestations like, yes, Roth spot, okay, Osler's node. Then you have the microbiological criteria that is not suggestive of major criteria, okay, like serologies. Okay, so are you diagnosed? What are the what is the distribution of criteria for diagnosis? Yes, so you have to remember those. Mostly treatment of choice is penicillin group of drugs, okay, and if it is resistant then you go for vancomycin.